within this track. Thank you. I'm very glad to lead this journal club with Dr. Earhart today. So today we are going to talk about the dual health randomized clinical trial. Just a brief introduction to the background. So many previous studies and guidelines suggested vitamin D, omega-3 fatty acids, and exercise may prevent age-related chronic diseases. But some recent large clinical trials show no benefit of these interventions in relatively healthy older adults. So these clinical trials, they aim to study whether vitamin D, omega-3, and the strength training exercise program along or in combination could prevent some health outcomes for chronic diseases among relatively healthy older adults. And this study was a randomized double-mask, placebo-controlled, and multi-centers clinical trial, which uses with a 2x2x2 factorial design. And it has 3 primary treatment comparisons. So it has the vitamin D versus placebo vitamin D, the omega-3 versus placebo omega-3, and a strength training exercise program of 30 minutes 3 times per week versus an attention control exercise program. So what is special about this study is its factorial study design. For a factorial study, it normally has 2 or more factors, and for each factor has 2 or more levels. And in a clinical trial setting like this study, the factors are usually different types of treatments. So here we could see that each participant could be randomly assigned to 8 treatment groups for different combinations of the levels of the 3 treatments, three interventions, as shown in this graph. So here we can have a question. So why do you think the author choose to use a factorial design for this study, and what could be the advantages and disadvantages of the factorial design? Does anyone would like to answer this question?
I could throw in a pro. It seems that it could be cost efficient by putting all those interventions into one trial versus doing multiple trials.
Yeah. So you mean it can help to improve the efficiency of the trial?
Yeah, and I think that's a good point, and I think it depends a lot on what your premise is, right? If you think that these these act independently, then you really have 3 experiments in one trial, or whether you think there is interaction between those treatments. Then I think it's not so much efficiency, but really a true design where you can tease out whether combined effects, for example, are better than individual drug effects.
Yeah, I agree.
But it also has statistical disadvantages. Wanted to mention that briefly, and we see this in this trial. I think they are so because of the multiple comparison problems, so they're operating with a p-value at an alpha level of 0.01, and they work with 99% confidence intervals. So that's a hard bar to cross, depending on the number of comparisons.
Yes, so they need to adjust the significance level for multiple testing. And any other thoughts? Yeah, as Dr. Earhart mentioned, the interactions when if one is interested in estimating the interactions between factors, they could use a factorial design. And I think it's an essential design when it is essential to be used when, for example, a single therapy fails to prove the effectiveness in clinical trials despite the strong preclinical evidence, or or they assume the complementary mechanisms of the efficacy of the treatments. And sometimes a treatment could be limited to a ceiling doses because of its undesirable side effects that could limit its compliance. So they could use a factorial design. And some other, could you think of some other disadvantages for such a study design? I can show some.
Yeah, I was going to say another sort of advantage as well that sort of ties in with that is actually that it's not bad for testing when you have sort of different types of interventions. So you've got here like sort of exercise and supplementation, right? So that sort of is nice for testing different groups of things together or in combination or separately.
Yeah, and I think it could help to improve the generalizability of the inference. Cool. Yeah, so we may also need to consider about the sample size and statistical power when we use such a design. So the sample size should be adequately powered for each component and each primary outcome of the factorial design. And also if the study assumed for the interaction should be considered in determining the sample size. And there are also some other potential disadvantages of such a design, like it may lower down the recruitment of the study, or it could impact the protocol compliance because of more assessments and interventions may be involved in factorial studies. And we may also need to consider about the participants' safety, that it could be hard to ascribe the adverse events to a particular treatment. Okay, so let's move on. This study enrolled participants 70 years or older who live in communities, and they have no major health events, and they have sufficient mobility as well as a good cognitive status. And they excluded participants who took more than 1,000 international units per day of vitamin D during the 3 years prior to enrollment, and or unwilling to limit their vitamin D supplement intake and the calcium supplementation. And they also excluded participants who took omega-3 supplements during the 3 months prior to enrollment and or unwilling to avoid omega-3 during the trial. And for the randomization and masking,
can I make a quick point? It's interesting that they chose a relatively healthy study population here, right? So and maybe they are paying the price for that. But why did they? I mean, they knew what they were doing. Why do we think they did that? It's an open question. I don't think I have a really good good answer for that.
Good.
I mean, maybe it's for logistic reasons. So they wanted people who can provide informed consent, people who may be able to come for study visits and all that. So that might be one reason. Otherwise, we do our best to oftentimes at least to choose a sample that is as thick as possible, such that we actually get to observe endpoints.
They weren't super healthy though, right? They said 40% had a history of falling in the prior year, so it wasn't too bad.
Yeah, partially, right? So I think in some areas, of course, it also has to do with their with generalizability. So what do they want to so what's the population they want to address here? And it seems like it's community dwelling, relatively healthy folks.
Yeah.
It could also sort of be the question that they want to address, right? So the two questions would be, we want to show this is better than to support use, but sort of the other side of that is this is commonly used and we want to see if it actually is something that does have an effect. So sort of checking that, right? And so if you take sort of the more general healthier people who are told to take the supplementation and then you find there's no effect, then maybe your conclusions would be finding that it's not worth it for people to take it.
I think, Stefan, like one of the interventions, actually the strength training exercise. So that limits things. So we probably have to exclude the population that are like contraindicated for any exercise at all.
Yeah, and that also goes back perhaps to the study design. So you need to be so you have a contraindication to one of those. That means you're not eligible for the trial if you have a contraindication to one of the three interventions. But we will talk about the strength training anyway, because I think that's an important factor to consider, how they delivered it and what exactly it was towards the end.
Yeah.
Yes, exactly.
Mm-hmm.
Yeah, that's a good point. So let's continue. The study used the stratified randomization with a block size of 16, and the participants were stratified by recruitment center, prior for sex and age. The central randomization center was responsible for the randomization and the masking, and the participants, staffs, and the data analysts were all masked in this study. All the participants were randomized to 8 treatment groups, as we mentioned before. So it has 6 primary outcomes, and for the counts of the non-vertebral fractures and infections, they were measured at baseline, yearly clinical visits, and telephone calls every 3 months, and they were modeled as rates. And 4 continuous outcomes were measured at baseline and yearly clinical visits, and they were modeled as change from baseline. And they represent different domains of the house. So for the sample size calculation and statistical analysis, 2,152 participants were required for this study. This study used the intention to treat analysis, and the GEE and the linear regression with correlated residuals were used to account for the correlations within correlations of the measurements within individuals. Poisson regression was used to model the non-vertebral fractures and infections for their incidence rate ratios. And all models were adjusted for some factors. And also they said the significant treatment interactions were found for the SPPB and infections, so that they included the 8 interaction terms in the regression models for these 2 outcomes, and a significance level of 0.01 was used in this study. So does anyone has comments for the master section? So actually, I do have a question that maybe it's not correct, but so they said they assume no statistical interaction between the treatment groups in their sample size calculation, but they actually included some interactions in the regression models. So I wonder whether it could raise some concern that it may increase or decrease our chance to detect the main effects of the interventions.
Well, I think that's always the case. I mean, I also reacted the same way because there are so many terms in the regression model that reaching a saturation point quickly, we don't know what sample size to take when we consider interactions, really. And even if we have only main effects, we're really not good at that. There are different rules of thumb. However, you are correct. That is on my list of concerns.
Yeah. Yes, thank you so much for answering the question. And any other comments for the master section?
Yeah, I just have a general question about the sample size calculation. So they have multiple outcomes, and I think the way that they define the results of the whole calculation is they define the delta, for each of the outcome.
Primary outcome,
Yeah. So is that a common thing to do for factorial design, or is it kind of a thing that you have to accept when you have multiple outcomes?
I think that's a good question. I think they should choose the sample size to make the each component of the factorial design to be adequately powered, and also for each primary outcomes. So, yeah, this is just my thought. So anyone else would like to add in something here?
Well, did they take the maximum of all of those that you just described? That is, figure for each factor and each of the outcomes, what would be the sample size with the p.01, and then whatever the maximum is across all those. Did they take that? I don't think I saw that.
No, I think the way they presented it is that so they listed the results of the calculation of sample size. That would be approximately 2,000 people, and they listed all the deltas from each of the outcome.
Right.
Yeah.
They didn't specify or try to list the reasons why they chose the specific deltas. So that seems concerning.
I think the deltas they mentioned that are based on some previous studies, but yeah, I totally agree with you.
Yeah, and for some they mentioned like something like the clinically the smallest clinically meaningful difference. I believe about the blood pressure changes. They mentioned that.
Yeah, that was.
Okay, thank you.
So let's move on to the results. From table 1, and we could notice that so the baseline characteristics were balanced between treatment groups, and they actually have a high mean MoCA score as of 25.7, and they have high SPP mean SPP score and baseline as 11, and also more than 83 about 83% of the participants have moderate to high physical activity and baseline. I didn't show the table 2 and table 3 here because they are too long, but from the tables, they said there was no statistically significant difference for any of the 3 treatments compared with their placebo or control in all the health outcomes over 3-year follow-up. And I don't think this result is important, but I would like to show it here, that they examine the effect of treatment interventions for the most frequently occurring types of infections. And they found omega-3 has a statistically significant effect for urinary infection and upper respiratory infection. So I think so for their results and conclusions, it seems like their results and conclusions are inconsistent with some previous studies and guidelines. Especially, they demonstrated that the strength training exercise program was ineffective on any of the health outcomes for relatively healthy older adults. So what do you think about the results? Like, for example, there are some guidelines. So the USPSTF, they suggested that regular and moderate physical activity could reduce the onset of chronic diseases in both healthy and chronically ill older people. And WHO also said it could reduce the risk of falls. So what do you think about the results of the study? Do you think they could have a strong conclusion for this clinical trial study? Yeah. So maybe I can go ahead first. Like the study mentioned they use the short physical performance battery, the SPPB, to measure the physical function. So and we noticed that it has a high median and baseline of 11. So it may cause the change in high functioning individuals to be missed. And also it is an integer scoring ranging from 4 to 12, and it may be insensitive to some small changes. So just some of the thoughts.
Yeah, so I think that's a great point. You know, I think for the strength part of it, our strength training, exercise, floor to ceiling effects are always a challenge when you're trying to look at especially sort of a healthier population. And one of the limitations they noted was that, you know, their people were all pretty moderately physically active already. Sort of considering also definitions and recommendations, right? You know, physical activity preventing or reducing the risk of sort of developing chronic diseases, that kind of stuff. I think it's still accurate, and the results of this don't go against that necessarily, right? Because there's sort of very long time scales that you need to evaluate those kinds of things. And so just evaluating maybe a little performance measure on physical activity or, you know, strength changes over sort of a short period may not represent necessarily, you know, the sort of the benefits in the long term of use. And then as for sort of the other interventions or the supplements, I'm not really all that surprised there. It's sort of similar, you know, there's been a lot of talk about whether supplementation is worth it for people who don't have a deficiency, right? Does it actually really impart sort of any benefit? And I just, you know, I was reminded of an older editorial from 2013 from one of our people in our department, Eliseo Guayar, Severio Stranges, Cynthia Mulrow. They put out an editorial in Annals of Maternal Medicine after sort of 3 papers in that issue talked about supplementation and didn't find anything. And it was, you know, enough is enough. Stop wasting money on vitamin and mineral supplements for preventing chronic disease when you're a healthy person. It's not doing anything. So I think that's sort of not really that surprising of a finding either for the trial.
Yeah, that's a good point.
Yeah, I just want to add I think that's right. The criticism here was really very much focused on the exercise intervention, saying it wasn't intense enough. You know, there was no room to grow in this active sample of community dwelling folks. That's more of a measurement issue, but many angry letters to the editor saying that, oh, now you're bashing exercise for elderly people because it wasn't intense enough what you tested. But I want to say this was a large trial, a large factorial trial. So so this is something to do something like this.
Yeah.
Yeah. So Dr. Yerhard said there are some comments for this trial, like someone argues they refer to a protocol trial that advised participants to engage in the home-based program for 30 minutes daily, but in their and that study found the program was successful in reducing falls, but in the Do Health trial they cut down the volume of the exercise program to 3 times a week. So one of the person argues that it may partially explain why they found the program to be ineffective.
So the other thing is the population. This population is after hip fracture. So you've gotten a much sicker population, much more likely to see benefit than you would if you took healthy individuals a priori.
Yeah, that's a good point. And they have a larger sample size of this study. And yeah, and also someone else, some people argues about the training intensity, like their training program is like only include the exercise for sit to stand, one leg stance, and some other exercise. So they think that it may not be moderate it may not be intensive enough for this healthy population.
Yeah. And I don't recall exactly, but I believe they had preliminary data on that exercise regimen. There was something, I believe, where they thought this was appropriate for that particular sample of people.
Yeah. So there are 83% of the participants and baseline who already engaged in the moderate to high physical activity, and I consider it may, so this exercise program may not be intensive enough for this population. So we mentioned some limitations of the study, like for so they have the ceiling effects for the ceiling dose for some of the effect for the MOCA and the SPPP score, and also there are some there may be low intensity for the exercise program. So what other limitations could you think of this study, and what do you think are the strengths of the study?
Well, there could be a drop-in effect. There always is in a trial with exercise, and also the products that the other two products they're taking are available in most pharmacies. So why couldn't someone who's randomized to the control for those two, you call them drugs, why couldn't they be buying them and taking them all along?
Yeah.
I think another strength is that they actually try to measure those the substances in blood. They present, I believe, they present mean values here per group. So I think there's probably better ways to present these data, like people who are who reach a certain threshold in those groups. But they did that too. So I thought that was remarkable that they actually tested whether those drugs were taken.
Yeah, I totally agree. And it could help to, I think it's the main reason that they have a high adherence for this, for the protocol.
Right, but were they testing only for those that were supposed to take the drugs? What about the ones who were randomized to control? Were they testing to see if they had taken the drugs?
Yes, they test the serum concentrations of the agents for all the participants, and stratified by different comparisons of the treatments.
Okay, so there what was it here? There might have been drop-ins for the exercise, but apparently not for the drugs. That's good. I didn't catch that.
Yeah. No, it is showed in the supplements, so I think that's a good question here.
They also manufactured the drugs for the trial, so that kind of helps with formulation as well and the potency.
Yeah. And I have another thoughts is that so the exercise program may not be good enough, but because it is very simple to, it is simple for the participants to follow. So it may also contribute to their good adherence to the exercise intervention.
And another strength of the study, if you will, is that, this study was good for people. The systolic blood pressure decreased across the board in everybody between 7 and 10 or 11 millimeters Hg. So I thought, so being in the study somehow was good for people.
Yeah.
Unfortunately for the investigator, not differential by study group.
That's a good point. Anyone else have some thoughts for this study?
One thing I didn't find is about the evaluation of frailty. So they took an older population, but we know that old isn't, it's a very heterogeneous group. So, and they didn't divide them. So maybe, especially comparing this to the study with the hip fracture patients, maybe the hip fracture patients were all frail, and here the proportion of frail was too low to get an effect.
Yeah, that's a good point. And they said they included 40% of the participants with a prior fall in the study to represent the frail old people, and I think it could be a good design.
Yeah, depending if you see a prior fall is enough to define frailty or not, and maybe I think there are very different kind of falling. So I don't know if it suffices just to say if you have fallen, you're frail.
Yeah. Yeah, that's a good point. So anyone else would like to add in something here?
This is just a random point, but I thought that their retention was really impressive. Like 2.9 years on median. Yeah, it's pretty good.
Yeah, agreed.
And I also think because they are healthy older population, so they are less likely to withdraw because of their health condition, and also the interventions don't have many side effects, so they don't need to worry about the adverse events that may cut down the compliance of the study. That could be the reason for their high adherence and high retention rate. And so what do you think could be some ways that we can use to improve the adherence and retention in our study? So I think maybe so normally we can add a running phase in the study to improve the adherence. And like this study, I think they are very quantitative in measurements of their adherence by measuring the serum concentration, and also they have a compliance questionnaire measured at clinical visits. So it could help to measure their compliance more accurately, and also they could monitor the adherence over the follow-up. Okay, so that's what I have here for today. Do you want to comment anything else for this study?
Maybe a question. What do we think about the design for this question? Do we like the factorial design, or do we think like a 3-armed trial would have been better? I think that's at the end of the day, I think that's the test, right? Is that study design good for the question you want to solve?
I will point out that I think factorial designs are really hard to get right, because the sample size calculations tend to accumulate all the different things that we have to make guesses about. And so, for example, I bet you in this study, they wish they'd made the sample size a bit larger, and maybe they would have gotten what they could have considered more positive results in at least some areas. And I don't think there was any way for them to know that in advance, other than do a regular sample size calculation and then just inflate by some factor that you make up out of thin air just in case. And who is going to pay for that? Nobody.
Yeah. And there are just too many testings. I don't think 0.01 significance level is as low as enough.
By the way, Mingyi, did you or anybody check where that 0.01 comes from? I didn't see that mentioned. I mean, they mentioned that they decreased the level, but I don't see any rationale for that. Why not 0.02?
Yeah, I think there are no specific, there are no defined criteria for the significance level. Maybe they just they think they should lower the level, but
Right. So they acknowledge the multiple comparison thing, but I don't think they give us a rationale for that p-value.
Yeah, there was no rationale.
I didn't see a specific thing either. It could just come down to sort of their training as well. You know, now I've had epidemiology courses at undergrad, master's, and PhD level in 3 different institutions, right? And thinking back to some of the very first things that I was taught, you know, some of the very first introductions to p-values were in the sense of, you know, 0.05 is often the standard, but if you want to be more specific, you can use 0.01, or you want to be more sure, you can use 0.01, just like as a very blanket, simple approach. So if investigators never got anything more than that or beyond that kind of an introduction to simple approach, they may have just thought let's just use 0.01 as a more specific, right, more confident in our answer than 0.05. But it's not a very good rationale, but it is one.
Actually, on that topic, they didn't adjust for multiple testing, I don't believe, and I didn't see anything about that. So if they and still they still didn't find anything statistically significant. So if I'm right that they didn't adjust for multiple testing and they did find something that was statistically significant, wouldn't people say, well, we all know that the vitamin D isn't any good, that's just spurious because they didn't adjust for multiple testing?
I think my guess is that their use of 0.01 instead of 0.05 is their very informal adjustment for multiplicity.
I agree with that, but perhaps each test should have been at 0.001. I don't know.
Right. There's a lot of tests in there.
Yeah. So they're lucky in a way that they didn't find anything statistically significant, because that really shows that these treatments are not effective. But if they did, they would have to defend the multiple testing. But let me ask this question. I take all of these, we'll call them drugs, and I do this exercise. Should I stop?
No.
Please tell me I should. Well, Mingyi, what do you think, since you're the chairman? Should I stop?
But it would be a waste of the resources of the trial. Yeah. I'm not sure about the answer.
That's a good point. Maybe it's maybe it depends on your resources, Jay.
Yeah.
Actually, Jay, it depends on whether or not you're frail.
Well, we all know.
Yeah.
I mean, so I mean, I think it's a bit like, I find these results a bit like aspirin. Aspirin clearly prevents second heart attacks and has no benefit to prevent the first in people who are otherwise healthy. You know, if you're otherwise healthy, maybe the two drugs the two vitamins, the vitamins and the omega-3 fatty acids don't matter. And that assumes you've got a decent diet and that you're healthy. But if you were to be osteoporotic, vitamin D might make a big difference. Similarly, if you were to be osteoporotic, exercise might make a big difference. So I do think some of this has to do with the population to which it's applied. And I said, are you frail, tongue in cheek? But I think that's actually probably that may be a significant, an important answer.
I think you're right. No, that is a very good advice.
Can I have one more question? It just occurred to me that is there any restriction to the antihypertensive medication that the participants can receive during the study?
No, they state that about half of people, if I recall that correctly, are on antihypertensive medication.
Yeah, because that's tricky. So basically, if one of the group, like the participants, have worse blood pressure during the study, and then they adjust the dose for their antihypertensive medication, then that will probably influence results we got.
Yeah, I think that's a good point, and that occurred to me as well, Molly. Yes, because their physician will or might adjust the medication if if the hypertension gets worse or something like this.
Yeah.
Okay. Any other thoughts? Okay. So that's what I have for today, and thank you so much for your participation, and also thank Dr. Earhart for the guidance. If you don't have any other comments, I hope you can enjoy your weekends. Okay.
Thank you, Mingyi.
Bye-bye. Yeah, thank you.
Yeah, thank you.
Bye-bye, everybody.
Bye-bye.